from the private sector, a great combination to see that how men in that position of influence and in that position can make a difference. And you will hear from them shortly. And of course, then we have a very a combination that was necessary. A young woman talking about young people, youth and adolescent. Pakistan being a very young country in terms of the age cohorts, we have 65% population below the age of 30. So if we don't take youth and adolescent into family planning or reproductive health program, then we cannot aim for what we are aiming for. So with that, I would like to introduce our star-studded panel today. But before the panel, let me just quickly take you through. I think most of you have seen the structure of today's meeting. But after I have spoken and introduced my participants, I'll say a few words about what are we trying to achieve through this panel discussion. Then I would invite Dr. Talib Lashari to give his opening remarks. And then there will be a presentation from Ipas Senior Community Engagement Advisor that will, do the real context setting. My opening remarks is really about the impressions and the things that I see it as I sit in this panel. And then there is a documentary to follow that, which will be managed by the Ipas team. Then the main crux of this session is going to be a panel discussion. As I said, there are three men as champions, which I'll introduce in a while, and one women leader I'll be asking few questions, and it will be very interactive, and we'll take it on from there. So this is how this 90 minutes are structured. And the objective that we are trying to achieve, I could say, if I can take the liberty, and I know IPAS is very generous, they would let me take that liberty, that, there are different framings that have been used when we are talking of men in family planning program or reproductive health. They have been engaging men as supporters, men as, as being partners, men as partners. So there have been several framing that have been used. And, everybody would say that Pakistan is a patriarchal culture and men takes most of the decision, which is true, which is a bitter reality in that sense. But I would also like to, draw a line here that, of course, it is extremely essential to involve men into family planning, supporting their wives, supporting their partners to take their decisions. But in that context, we should not take away the empowerment angle from the women itself. So not at the cost of taking away that men are making decisions for women, but it should be really about how they can be supportive, how they can be, provide them with that social support that a woman needs when she takes family planning decisions. So men as an ideational game changer can only support a woman to take to that empowerment angle. And we were trying to see that how this could be done. There are a few examples that we will see. There will be some evidence, and we'll try to reach some of the things that can be taken away as best practices or maybe as a suggestion or recommendation. So this will be about today. Let me introduce my star-studded panel. I'll begin with Dr. Nasir Mohiuddin, who is, everybody is an old colleague, so I don't need to say it again and again. But, he's of course, a medical doctor. I think most of the people there are. With an MPH degree, has held some great strategic position with the federal government. His last position, which was, I think, very recent, was the DG Health in the Federal Ministry of, it's a longish name, but it's the Federal Ministry of Health and Regulation and Coordination. And then he has been in charge of NIPS, which is a, which is a research institute, and he has been the principal of Regional Training Institute in Islamabad. So you could see his journey that, he has been to those positions and he can reflect so well. Dr. Talib Lashari is our, is our champion. He's our to-go person. All of us look at him for an advice when we are working in Sindh. So Dr. Talib is a public health specialist. And right now he's an advisor to Population Welfare Department, to Department of Health. In Government of Sindh. He also sits in the Chief Minister Task Force. He is the convener and a coordinator for Sindh FP 2030 working group. And he is also has worked extensively in the health policy. The CIP cell that he's managing is something that he sort of crafted and developed So Dr. Talib Lashari has many dimensions to his work, which we'll get to know as we will speak to him today. Dr. Ghulam Shabir Afwan is the Ipas country director. I would say that Shabir has led a very difficult pathway in the most strategic and astounding, leadership. I mean, this is extra, not what is given to me. But he has years-long public sector experience. He has worked in UNFPA. He has also worked as a UNFPA advisor to Ministry of Health, and now he's been with the. I think he has the experience of 12 years, and he has been IPAS with several years. And we all look at IPAS when there is post-abortion care and post-abortion contraception. Last but not the least, the young woman that I have been referring to is Ms. Amna Aksheed. She is the general manager at Punjab Population Innovation Fund, PPIF, which we call it. And she has remained with the FPAP, another major, family planning organization in the country. And she has a special interest in youth and adolescent work and SRH information and services in Pakistan. So with that, and she has done her master's from LSE, and I was very impressed to see that she has been given an award by Prince Charles. So that's a new information, Amna, but that shows you have a global outreach and recognition. So good to see that. And with that, I would like to pass the floor to Dr. Talib Lashari to give his opening remarks. Dr. Talib, over to you.
Thank you, Dr. Yasmin, for your generous introduction, and thank you, Ipas, for organizing this very crucial session at the eve of the 65th session of the UN Commission on the Status of Women. The topic is indeed very important topic that talks about men as supporter of women in post-abortion contraceptives uptake. We know that in our journey into the family planning and reproductive health in Pakistan and in the developing countries, some of the unexplored areas have been there, which have, if addressed from time to time, these might have provided a big jump into the contraceptive prevalence rate. So one of those areas is engagement of the male. Others are post-pregnancy family planning and engagement of the adolescent and young girls and women and boys. So these are some of the areas which really need our attention of the policymakers and the managers and implementers. So I'm glad that today we have IPAS and the entire team has selected this very important topic. And we know that engagement of male is something which is not only now being discussed in our policy circles, but also it has been now reflected in the Supreme Court-led suo motu, which led to the Council of Common Interest recommendations, and that talks about the engagement of the male, and it now involves some thought process in the provinces at federal level and at provincial level. As we know, after the 18th Amendment, the provinces have to implement the programs and the plans in coordination with the federal government. So I think it's a very important and timely discussion that we are holding. And I think this discussion will not stop here, but we will continue this discussion in coming days, months and years to really engage the men. We know that there are around 5 stages when male could be engaged, like during their life cycle, at the level of adolescents, at the level of when they become active sexually, newly married, first-time parents, during the time of spacing, and once they have completed their family size. So these are stages where we need to really engage the male, and we also know that through the scientific literature that the uh, behavioral norms and the social norms of the male around the sexuality are formed at the early stage of adolescence. So I think that brings us to some sort of a comprehensive strategy that is needed for engagement of the male. So I think during the rest of the session, we are going to have a very productive discussion, especially in the presence of you, Dr. Yasmin, and Dr. Nasir, and Dr. Shabir, and of course, Amna, who has been champion and working on these issues. So I think this panel is going to provide lots of insights, and on that, Ipas and we as a whole community will be working in near future. So thank you so much.
Thank you, Dr. Talib, and thanks for reminding that working with men is a part of CCI recommendation and is a high-level policy, guidance. With that, I'm going to pass the floor to Ipas team, who will be doing next two things. Over to you guys.
Thank you, Dr. Yasmin. Samina, I will be sharing the screen. Please take the mic.
Yes.
Please, Samina, take the mic.
Thank you, Mehreen. Thank you, Dr. Yasmin and Dr. Talib Lashari, for setting the context so beautifully. Hello, everyone. This is Samina Sabir. I'm working with Ipas Pakistan as a senior community engagement advisor. I hope and I wish everyone is safe. Today, I'll be sharing Ipas Pakistan work on engaging men as supporters of women in post-abortion contraception uptake. Next, Mary. So I'll start with giving a very quick update on the Pakistan context. According to a national study conducted in 2012-13, there were 2.2 million abortions recorded each year in Pakistan, which is a 100% increase compared to 2002 data. And we all know that 25% of all the pregnancies and 50% of unintended pregnancies in Pakistan ended up in abortions. Every province has different abortion rate, with Sindh and Balochistan having the highest, up to 63% abortion rates. Also, the same study reports that 700,000 women each year visited health facilities for post-abortion care and post-abortion complications. We at Ipas also maintain our own data at Ipas intervention facilities. So per our data from 2012 to 2020, out of the 70,000 plus women who visited Ipas intervention facilities, more than 90% were treated for post-abortion care at these health facilities. And more importantly, these unsafe abortion and unintended pregnancies are contributing to maternal mortality in Pakistan up to 13%. Next. So we at Ipas, we believe that we need to intervene to break this vicious cycle of unintended pregnancies, to save women's life and to contribute to addressing the issues above. There is enough evidence that by improving accessibility and contraceptive use, these issues, these maternal deaths can be reduced by up to 35%. The more important issue to focus, we believe, is post-abortion family planning, because we believe that's a double missed opportunity. There is high stigma around abortion, and that spills over post-abortion family planning as well. There are myths and misconceptions among community intermediaries, both male and female, and providers. So they lack the very basic knowledge on early fertility return of 8 to 15 days after an abortion. Per IPA survey, 68% of the 18 FWAs we surveyed, and 78% of 865 lady health workers had no knowledge on this. They all believe that fertility can return after 40 days. Some said it will return after 6 months. So resultantly, these women who undergo abortions do not get high quality post-abortion counseling and contraception. And this vicious cycle of unintended pregnancies, unsafe abortions, maternal death continues. Next. So Ipas is working in Pakistan to contribute to addressing these issues since 2007. So our main focus is around three major areas. One being policy environment that supports women and girls access to high quality post-abortion and post-abortion contraceptive care. And then making the high quality post-abortion and contraceptive care available at the health facilities, both private and public. And also at the same time, sensitizing community women and community girls on these issues and equipping them with correct knowledge so that they can have that self-confidence to access these services and contraception services. Next. Just to give an overview of the trajectory in Pakistan for the last 1 decade, which shows the milestones achieved with the collaborative efforts of many different government and non-government organizations. So it starts with Karachi Declaration in 2009, which was a pledge by government and non-government stakeholders to strengthen post-abortion care in the country. And in the same period, Pakistan Alliance for Post-Abortion Care was formed, which comprises of members from many different organizations, government and non-government. Moving to 2013, WeCate and clinical trainings were piloted, and there were task shifting initiatives in Punjab and in Sindh by involving midwives and training them on MISO and MVA. Moving to 2015, Ipas Pakistan piloted SBC toolkit for lady health workers for social and behavioral change in Punjab, and the first standard and guidelines on UE and PEG were approved and implemented in Punjab. SOGP, which is very a crucial body, they cleared their position statement on post-abortion care in Pakistan. Moving to 2017, Punjab government procured 10 million MISO and 5,000 MVA with the government budget, which is another milestone. And DRAVE included MISO in the national drug list with some expanded indications. Moving to 2018 to 29, the national SNGs were approved at national level by ministry. Ipas Pakistan, with collaborative efforts with the government, trained more than 500 lady health workers on these SPC tools and safe pathways. Clinical trainings were expanded to secondary and primary level health facilities. The last year was mainly about Sindh because they adopted national SNGs. They worked on PFP policy and developed an implementation plan around PFP. And also Ipas Pakistan piloted the engaging men with through the male community intermediaries, which are called family welfare assistants and social mobilizers in Islamabad district and in Sindh with the help of ministry and provincial government. Next. So why engaging men? We all know this has been discussed earlier, but as mentioned earlier, Ipas Pakistan has been interacting with community women through lady health workers through in their community session since 2015. And there was a very clear and loud message from community women that if we are going to reach anywhere in this post-abortion care and post-abortion family planning uptake, we need to involve and educate community men in this agenda. Also, as mentioned earlier, that Pakistan is a patriarchal society. Men as husbands have very strong influence in every decision of women regarding every aspect of their life, including family planning. And unfortunately, men have largely been excluded from the programs and interventions that aimed on family planning, and so are these male community intermediaries. Next. So who are these male community intermediaries? They are designated as family welfare assistants and social mobilizers. They are government employees. They work under the population welfare department. They both have their specific outreach area in the community. So they both counsel community men and male dependent contraceptives, and also create referral linkages for women for LARC to their concerned facilities, which are called family welfare centers. Next. Correct. Next. Powerful. So talking about the journey when we thought and when we decided to work on engaging community men as supporters for community in post-abortion family planning, we started with a CAPE survey, knowledge, attitude, and practices survey with family welfare assistants and social mobilizers in Islamabad. Next. Here are some of the findings of that CAPE survey with community intermediaries, which were basically from Islamabad district. Regarding their knowledge on contraceptive, 21% shared that FP is the use of contraceptives by females only. 26% believed that natural methods are reliable and more effective. 68% had no information on fertility return, and they said fertility return after 40 days after an abortion. Regarding their knowledge on post-abortion care, 74% had no information on post-abortion care and its element, and 47% had no information on the complications after an abortion. Regarding when we talked with them about men engagement, 53% of the respondents believe that men are not willing to talk about contraceptives, and 32% said that it's their private matter, so let it be. And then talking about the reasons for less FP uptake, the reasons cited were the fear of the side effects and religious misinterpretations and misconceptions, specifically regarding male permanent method, male-dependent permanent method. Next. So once we had the findings from this CAPE survey, we were able to identify the problem areas. We defined the problem areas, and we went back to the same group of family welfare assistant and social mobilizer to have their insights on those problem areas. And then we, together with the family welfare assistants and social mobilizers, and also the Director General and his technical team that time, we went through many rounds of co-design session to develop some kind of intervention to address these identified problems. And then we tested those prototypes with the same group, and in some places within the with the community men, they were revised based on the users' input, and then they were technically reviewed by different stakeholders, including the population wing of the Ministry of Health. And then there was approval process from the Population Welfare Department, Population Wing, Ministry of Health, and the provincial government in Sindh. And then we piloted them with family welfare assistants here in Islamabad district and 2 districts of Sindh. And then we kept documenting our experiences, and here we are disseminating those. Before going forward, I would like to share that our intervention is still very young. It's only 1.5 or 2 years old. It has not been that much time, but we are sharing whatever we learned in these 2 years. Next. So after all this process, what we had in hand was a set of these 4 SPC tools. The objective of these tools were to help the social mobilizers and family welfare assistants to initiate a dialogue with community men. So there are 4 tools. The one is called Title Story. There is Safe RH Care Pathways, and then there is 4 delays tool, and then there is a list of contraceptive method. The approach we follow is for implementing these tools in community is through storytelling, so that community men can relate to this, and also to make them relatable and attractive for them, we linked every story with quality of life. So we also developed a detailed user's manual or trainer's guide with these tools, which I will be discussing the tools one by one in the next slide. So this is the title story or the theme of the whole intervention. In the user's manual, we explain this tool by sharing a happy and prosperous couple who take every decision or who do every planning regarding every aspect of their life with mutual consultation and mutual respect. And thanks to, and we show that thanks to that planning, they are able to improve their quality of life, and they also have healthy healthy gap between their two kids. Next. So the next is the reproductive healthcare safe pathways for married couple. It starts with the premarital counseling, where we talk about the age of marriage, we talk about nutrition, we talk about STIs, we also talk about mutual respect, and more importantly, we talk about sensitizing soon to be married young girls and boys on family planning. Then it talks about through storytelling, definitely, about after marriage, the first delayed pregnancy, because this is again highly stigmatized, and per our interaction with family welfare assistants and lady health workers, these community intermediaries have their own myths and misperceptions regarding first delayed pregnancy. So even if a couple, if a newly wed couple comes to them for information on contraceptive, they discourage them, like have their first kid immediately after marriage and then talk about family planning. So we try to address this as a basic human right. We should at least be providing correct information to them, and guide them to a safe pathway, which is through lady health worker or through their family welfare assistants and the trained providers. The second pathway is about intended pregnancy, then antenatal care, postnatal care, and postpartum family planning. And then it talks about and during an intended pregnancy, abortion can happen, spontaneous abortion can happen requiring post-abortion care, and what's the safe pathway in that case. We try to explain that through stories in the user manual. The last pathway is about unintended pregnancies, and then it further divides into two pathways, safe and unsafe. The safe one goes through lady health worker and family welfare assistants and social mobilizers to a healthcare facility where a trained healthcare provider is available, who then counsels them after giving necessary post-abortion care, who also counsels them on post-abortion family planning. And then there is an unsafe pathway which goes through an untrained person who is called DAI in Pakistan. And then there are consequent complications, but the lady health worker saves the life of this woman by taking her to the facility. There are two key messages, because these were the highlights of the CAPE survey, that they need an information on fertility return period after an abortion, and then they need information on the effectiveness of long-acting reversible contraceptives. Every pathway ends at the contraceptive methods. Next. So the third tool is 4 delays based on the WHO's famous 3 delays model. With this tool and through different simple stories, we try to highlight the role of husband and the role of mother-in-law in identifying post-abortion complications and timely decision-making, and taking the woman to the hospital, and then where a trained healthcare provider is available. So the story goes like there is a husband who is wise, who is sensitive, who understands the danger signs, who takes timely decision, who takes his wife to a facility where trained providers are available, and then after giving necessary paid treatment, the provider also counsels them on the post-abortion contraception, so that they don't have to go through that cycle again, unintended pregnancies and unsafe abortions again and again. At the red side, there is a careless husband who an unsupportive mother-in-law. So there is no arrangement for travel, and there is no, they do not take their women to the facility timely, and then the complications, the cycle of unintended pregnancies and unsafe abortion continues this way. The last one is, again, a very simple tool. It describes the list of methods for different circumstances for delaying first pregnancy, for postpartum, and for post-abortion. We have also given very simple messages like the complications of early age pregnancies, and then what is reliable, what is most reliable, what is least reliable. And then there is a misconception on this 2 years birth spacing. So so we are giving this message of 3 years of birth spacing, including the pregnancy period, and what is suitable for a breastfeeding mother. And also any method can be taken immediately after in a successful and uncomplicated abortion. So these were based on the findings of CAPE survey and also our interaction with male community intermediaries. So this is the trainer's manual, and we have translated the trainer's manual and the tools in Sindhi, in Urdu, so that these FWAs and social mobilizers can use them in their daily routine while interacting with community men. So once we had the tools approved and finalized, our approach for training is a cascade model. We started with the district training instructors in Islamabad and in Sindh. We have trained to date 14 district training instructors. These are representative from the district population welfare offices. Then these district training instructors train their respective family welfare assistants and social mobilizers. And to date, we have trained 35 from Sindh and Islamabad. And then these family welfare assistants and social mobilizers have trickled down the same messages using this storytelling methodology and these tools to more than 300 men in Sindh and Islamabad. These are some of the pictures from our different activities with community men, with FWAs and social mobilizers. So this is an immediate result. As I mentioned, it's not that old, it's very young, our intervention. So we recorded a baseline into 2019, and then we touched base with these in 2020. And there were many different questions, but we are sharing these 3 topics here. So if you see in the first one, post-abortion family planning choices available for a couple, from 2019 to 2020, there is an 11% increase in the information of these, in the correct knowledge of these family welfare assistants. About fertility return period, there is 62% increase, and WHO recommended safe method for UEPAC, there is 34% increase. So this one is for Islamabad. Next. In Sindh, again, the first one, there is no difference. In 2019, there was 67, and then post-training scores is the same, so there is 0% difference. Fertility return, there is 71% increase post-training when we touched base with them. And regarding WHO recommended safe method, there is 32% increase after our intervention. So the same questions we administered with community men, with these 308 community men. So per baseline, from compared to baseline in the post training and follow-up assessment, there is a 66% increase in their information on family planning method. What family planning method or what contraceptive choices can a couple have after an abortion? And then fertility return period, there is a 76% increase recorded. And on WHO recommended safe technologies for UEPAC, there is a 74% change or increase recorded. Next. These are some of the comments from FWAs, from officials, and from community men. So they talk about the role of men, and that we should also expand this to extreme rural areas, because they say like the intervention should be started in remote areas where education level is very low. They compare themselves that we are educated person, even we did not know about the issues as such. So this is from Sindh, from some FWA, and then there is one from Islamabad who says they can confidently communicate with community men now, as they have these tools in hand and a methodology to start to initiate the dialogue. And then there is one from DPWO Hyderabad that the material is very simple and easy to understand because it's in local language. And then there is one from Islamabad who are thinking a step forward, like, okay, we will use these tools, we are creating that awareness. But then when community people come to us asking about those safe pathways in case of unintended pregnancy or for UE, where should we guide them? So these were some of their concerns and some of their suggestions, which shows that the change process or the thinking process has started at the community intermediary level. The challenges we had initially, because these male community intermediaries, they have been working for 10 to 15 years. So it was really hard. It took some time to make them unlearn and to be open to learning and accepting this new information. And then managing community men's time, because these family welfare assistants and social mobilizers have defined working hours from 9 to 3, 9 to 4, whatever it is. But during those hours, community men go for work outside of their homes, to the city, to somewhere else. So managing these two, it was a bit challenging for us, but then we managed these according to their convenience. We started with a group of 3 people, where possible we held the session with 15 to 20 community men. Where it was not possible, we even followed in the one-on-one dialogue process. Thank you so much. This was it from Ipas. Again, our intervention is very young, and these were our learning from the last 2 years. Thank you so much. Over to you, Dr. Yas.
Thank you, Samina. This was really, really interesting. And I'm sure most of these things will be fed into the work. I think this is a time for a documentary, if I'm correct, as per agenda.
Yes, Dr. Yasmin, we have a short
Okay, please, Karen, go ahead.
Yes, sure.
The main causes of high rate of abortions in any settings is the high unmet need in family planning, and that could be that the people are not aware, or if they are aware, they are not able to access the family planning services. So the community men have equal important role, rather more important role, that they are the main decision makers in the communities, and these community intermediaries such as family welfare assistants or the social mobilizers, which are deployed by the population welfare department, and they bridge these communities with the providers or facilities. I think they could be the best source to trickle down information about family planning, the correct use of contraceptives to the men in their communities, and who can further support the women, and even their choices, where they can help them to choose the family planning method of their best choice. Post-abortion family planning is a high missed opportunity, that a woman coming for post-abortion care, if she is not getting counseling and a family planning method, she is prone to another unwanted pregnancy, and which can end up with unsafe abortion. So the men in the community, they can help the women to decide and to choose the method of their choice, from the providers or the facilities where these services are available.
Pakistani women have a high number of unwanted and unintended pregnancies, which result into abortions. Due to the cultural stigma associated with abortion, majority of service providers refuse to provide safe services, which result into unsafe abortion practices, which usually end up with many complications and even threat to the life of women. Government of Pakistan is fully cognizant of the problem and its social implications. In this context, I am really thankful to Ipas country team in Pakistan and their leadership for this very bold initiative to support the Government of Pakistan in sensitizing male community intermediaries on this very important and relevant subject. These male community intermediaries designated as family welfare assistants and social mobilizers have been trained by Ipas to build their capacity for counseling community men on post-pregnancy family planning and post-abortion care. We are hopeful that this sensitization of post-abortion care and post-pregnancy family planning will trickle down to the community men downwards. Ipas undertook this very first and very bold step, along with the Government of Pakistan, to discuss this sensitive topic of post-abortion care and post-pregnancy family planning and bringing down its benefits to uplift the health of women and well-being of community at large in Pakistan.
So user's perspective is highly important whenever we think about developing an intervention around the communities, for the communities. I think this is highly important, that how we involve or engage those communities and the people who will be using those tools, where through which they can pass on this information to the communities. So for this specific pilot project, we engaged with the community intermediaries, the family welfare assistants and social mobilizers to have their perspective about the communities where they are working around on family planning. And we were also able to know about the perspectives of the community when we were developing these tools for community men. So I think the major breakthrough or success of this pilot intervention is that we utilize that perspective of the community men and these community intermediaries while developing the social behavior change tools. And when they had these tools in their hands to engage or to pass on that information to the community men, they were comfortable because they are already aware that they were part of development of these tools.
It was a very learning and interesting experience for me to be a part of this intervention with such a learned cadre of community intermediaries of Population Welfare Department. We went through many different activities, including the development of SBC tools using a user-centered design approach, capacity building of family welfare assistants and social mobilizers on those SBC tools, value clarification and attitude transformation workshop were required, and trickling down the content to community men through community sessions. It was very challenging experience for me, but I must say it was very rewarding end of the day to see this change coming through.
कम्युनिटी में इस मौजूद हवाले से बात करते हुए हमें बहुत झिझक महसूस हुआ करती थी, लेकिन आई पास की ट्रेनिंग के बाद हमें इसकी आगाही के बारे में हमें इजाफा हुआ है और हमारी झिझक ख़त्म हो गई है। गैर इरादी अमल और उसके नतीजे में औरतों में पैदा होने वाली पेचीदगियों को कम करने के लिए हम एक अहम किरदार अदा कर सकते हैं। इस ट्रेनिंग के बाद हम समझते हैं कि अस्कात अमल के बाद माना अमल तरीक़ों का इस्तेमाल हर लिहाज से अहमियत का हमल है। अस्कात अमल के बाद 2 हफ्ते के बाद दोबारा हमल हो सकता है, लिहाजा इसके लिए बहुत ही एहतियात की ज़रूरत है और आगाही देना, कम्यूनिटी को आगाही देना बहुत ज़रूरी है।
हमारे माशरे में औरतों के मुकाबले में मर्दों को ज़्यादा मुश्किलात का सामना करना पड़ता है कि माशरे का ज़्यादा प्रेशर उन पर होता है। वो समझते हैं मेरी बेइज्जती न हो जाए, इस हवाले से फिर वो हम ये आगाही जो प्रोग्राम शुरू किया है, इससे काफ़ी फ़ायदा हो रहा है।
फैमिली प्लानिंग खुसूसन अस्कात हमल के बाद माने हमल के इस्तेमाल से मुतालिक कम्युनिटी में शकूक व शुबात पाए जाते हैं, जिसकी वजह से इब्तदाई मुश्किलात हैं, लेकिन हमने पहला कदम उठा लिया है। हम अब कम्युनिटी में मर्दों को अबार्शन के बाद फैमिली प्लानिंग के हवाले से सही मालूमात फराहम कर सकते हैं।
Thank you. Thank you for this very, very informative, Samina. Thank you so much. I think there are hardly any questions left to be asked after such a detailed presentation in both your documentary and in your presentation, but yet I'm sure there are many questions that we can ask. I would like to begin with Dr. Talib, if I may so, and I would also request all my panelists to turn on their videos so people can see that these are the respondents. So Dr. Talib, we heard many things which we already know, but how it is taken into consideration when a program is designed. You sitting on a very strategic position in Sindh government at a policy level, and we know traditionally family planning program in Pakistan are very women-centric. Women care and keeping women care as a model is, of course, definitely the kind of a right pathway. But in that, we have unconsciously filtered out the men playing any role. And now there is a conscious effort to bring them back. So we have heard about these, how community-based how can community-based agents or community-based workers or community-based organization can influence the men in the community, because that seems to be, especially the myths, the taboos around abortion and especially post-abortion contraceptive use. So we would like to hear from you about your experience and your reflection. Over to you, Dr. Talib.
Thank you, Dr. Yasmin. Once again, I think we have had presentation and the video very, very thought-provoking. So it triggers a lot of responses. But I think, as you also know, traditionally family planning is regarded as a women affair, that it's all about the women, and that's why mostly the men at home and within communities, they don't bother, they don't discuss, and they when such kind of eventuality comes, they feel that, okay, mother-in-law, sister-in-law, and my wife, they will all take care of it, and they just go away. As I've seen in one of the posters, that how the important delay takes place when a man is sleeping and woman is in a dire need of post-abortion care, and she needs to. So I think this is the taboo which is already there. Secondly, it's an issue of gender norms as well, because we in our society, being patriarchal, most of the time decisions are being taken by the male members in the family and within the community. So this also hinders the empowerment of the women and their reach, how they can reach to the facility and for a care, for family planning as well as post-abortion care and family planning. So as we know that due to the very low level of literacy in our society, and we know from the scientific evidence that it's the early stage of adolescence that sets the behavioral norms towards sexual needs. So I think somehow we are talking about the life skill based education, we are talking about the early child education. These are some of the tools that should have been and would need to be emphasized further. And also, as you have mentioned, that how these challenges and myths and taboos our workers can address, I think that is also a weak area. Our trainings, our recruitments and hirings have been mostly on medical officers and other cadre which can provide services to the female on the family planning. But the male cadre, which really would be going to the male members, like family welfare assistant male, although there's a female as well, FWA male, FWA female, and the social male mobilizer. And we know that both are mostly the non-technical positions. FWA male is a non-technical position, which means there's no level of training involved. That indicates that once we don't take these workers through the technical trainings, hence they won't be that much able to provide those services. But I think for the past 5-6 years, during implementation of FP 2020 and the CIP, and now linking that with the CCI and SDGs, we have seen that some of the trigger has been adopted. Male mobilizers have been motivated, female family welfare assistant male workers have been motivated, and we also developed a new source of information or cadre, which is not a permanent one, but through CBOs, that is called Sukhigar counselors. So the referrals by the social male mobilizers have a significant impact because they have gone through social mobilization for the male members as well as FWA male went through. So we have seen around 16,000 plus increase in the users, and the referrals were in more than 100,000 cases. Likewise, Sukhigar counselors have had nearly about 10,000 sessions in the communities purely for the male in remotest areas, and they were able to generate 8,000 plus users in the communities. So this is how they have been referring, and they have been generating the users. So I think what is important is, even we know that our female workers also counsel. When the couple comes, they counsel male as well. So we found that the male members prefer for a short-term method because they want their wife to be healthy as soon as possible, and then they continue the reproductive process, and for that they think that it's a natural process. So we don't want to stop it, and it's a natural process. But they don't know that short-acting methods, if they can prevent the health, the continuity of pregnancies will further compromise the health of the women. So I think these are some of the points that we need to think through. But a comprehensive male engagement strategy would be need of the hour in response to CCI, in response to our public policy.
Great, thank you, Dr. Taliban. That was going to be my next question about the strategy, but I would like to now bring in Dr. Nasser, because you have been a part of the work that has been done by Ipas for involving men. Besides Dr. Talib, what he has said, it seems to be really making a difference, and we would get to know it when we. So any policy change would need an evidence base. So this makes a lot of sense that we have taken that trajectory and pathway. I would like to know from you and from your own perspective about these cadre, this intermediary, when they were really given this task. What does it take? Because Samina was saying very nicely about you have to make them unlearn about the things that they have sort of a part of their mindset because of the social cultural things, because nobody has taught them about that. So taking that process of de-learning, take that out, bring in new learning, take out the myths and misconceptions, So what has been the experience of you working with this cadre, and what do you think? There is a ray of hope that we should start, putting some intervention and making some significant investment in this cadre. Dr. Nasir?
Yes. Thank you, Dr. Yasmin. Can you hear me?
Yes, we can hear you very well.
All right. First of all, I would like to thank you, Dr. Yasmin, and Dr. Ghulam Shabir and his team, Ipas team in Pakistan, and Dr. Talua Sharifa being here joining this session. It is really something, important to discuss and talk about this thing. Dr. Yasmin, I would like to take this opportunity, to speak about the family planning program in Pakistan generally, and then I will come back to this post-abortion care and abortion issue. Last census of Pakistan was held in 2018, and the findings were, amazing, rather astonishing for the government of Pakistan as well. And the number indicated that Pakistan has become the 5th most populous country of the world, and half of its population is consisting of female population. Majority of a large number of population is living in rural areas, and literacy rate in women is quite low. The PDHS conducted by National Institute of Population Studies during 17-18 year indicated that average number of women in Pakistan is 5 to 6, whereas the desired family size is 4 children. So this difference of actual family size in Pakistan and the desired family size reflect that around 1 to 2 children are unwanted or unintended, which families and couples don't want to have, but they are bearing it. It is mostly due to the situation of family planning program and its performance in terms of CPR. CPR, especially for modern contraceptives, is quite low, and most of the families, decide to go for or think of adopting family planning services when they already have 5 to 6 children. So for them, the most important and method of choice remains the tube ligation, or otherwise, as I think Samina has told in her presentation, that there are around 9 million pregnancies, more than 9 million pregnancies in Pakistan, and about half of them are unwanted and unintended. Out of these, more than like 4 million pregnancies, 2.2 pregnancies end up into induced abortions. And out of this 2.2, around 600,000 induced abortions end up with, post-abortion complications. So, this 500 women die because of this unsafe abortion services. This represents about 5 to 6% of MMR burden in Pakistan. So when I was holding my office in Ministry of Health as Director General, me and Dr. Ghulam Shabir, who is the country director of Ipas in Pakistan, we actually had a long discussion about this situation, and really I expressed my concern that government of Pakistan really wants to address this issue of unsafe abortion and post-abortion care services provision in Pakistan. So this was actually the starting point. We agreed to develop some intervention, which could be acceptable at large in service, because there is, social stigma and cultural sensitivity associated with abortion and abortion-related services in Pakistan. There is, let me put on record that there is an abortion law in Pakistan, which very clearly, allows the service providers to undertake and provide abortion services, maybe for saving life of mother or providing necessary treatment. But many of the service providers are, due to their own, apprehensions and not clearly having understanding of the abortion law, they tend to refuse to provide services. So this actually rather pushes the women to seek abortion services from backdoor and from untrained service providers. Normally, they who are a bit more, trained, let me say, they tend to use DNC, which is very dangerous. It has already been, banned by the WHO. And there are some, kind of chemical abortions. They use harmful substances to induce abortion and to dilate, uterus. So all these really bring a very bad situation to women, which can affect their health for a long time, and it interferes with their daily routine. And if they are working, and if they are working women, it can reduce their daily wages as well. And the most bad part is that many of the women go to unwanted death. And it is not death of only one woman. I always say, when a woman dies, it is not only one person, one woman. It is the whole family which is ruined. The children who are left behind, nobody is there to look after them. Husband has to go and for earning. And if he marries with another lady to look after his home, the lady normally doesn't have so much care as a real mother have that for those children. So it is a bad, very tragic situation. So with all this background, as I already said in my video, that Ipas has taken a very bold step and very important, very important step in collaboration with the government of Pakistan. And we actually think that men are very important. Luckily, Pakistan has a very strong family system. Men are very caring for their families, mothers, sisters, and wives. And when they are actually given the right information about abortion, about provision of abortion in law, and provision and importance of life, in our religion, they are convinced that they should be taking care of their wives when there is need. And post-abortion care is one of the areas which, by involvement of our family welfare assistants and social mobilizers in Islamabad especially, which we have experimented, it has been a very successful intervention. I must, on record, congratulate Ipas in Pakistan, and especially the visionary leadership of Dr. Ghulam Shabir, that we have been able to make a breakthrough. It was a difficult task, socially very sensitive, very difficult, but it has been, breakthrough, great breakthrough. And I think I would like to suggest taking advantage of presence of Dr. Talib Lashari, that this, because after devolution, it is now the responsibility of provincial departments. So they would be actually expanding this project to take this intervention in their own provinces and take it to the rural population. So far as challenges are concerned,
Can I come back, Dr. Nasir? Can I come back to you?
Yeah, please.
Talk about challenges, if you don't mind.
Yeah, I was just coming to this now.
Okay, if it is very brief, then you can say it. Otherwise, I have to post other questions to you as well.
All right, right. For the first challenge was that due to its cultural sensitivity and religious, sensitivity as well, the government of Pakistan has not been very openly take this intervention at the public sector level. And that is the reason that NGOs have been involved and they are encouraged to take this task forward. Challenges are there that service providers, they need to be, convinced that these services are very much legal and acceptable in Islam as well. And we need to actually, educate our communities as well to reduce social stigma associated with this post-abortion care and family planning. Right.
Thank you so much, Dr. Nasir. This is really helpful. I will now come to Dr. Shabir. You have been giving us lots of testimonials for your leadership. And of course, I can also give you a separate one. Everybody knows that the kind of work that you have been doing it's a very challenging task, but a very much needed task. So I want to really give you, kudos to you for your courage and for your strategic vision. So I have you have a couple of questions to you. So first, how did you come to realize that this is an intervention, especially post-abortion contraception, and involving men into it? Because involving men into family planning and a behavior change and creating a positive behavior is a task in itself. Why did you think of that? Because before that, you had involved lady health workers very effectively in post-abortion care and post-abortion family planning. So why? And the second thing, and Samina was showing the SPCC tools, and I would say what I said in my opening remarks. I would really like to ask you, or maybe one of your team member, if they can respond to what kind of message what training you give to your council, your FWAs when they talk to men. Is it about supporting their wives to take a decision? I hope they're not telling them you take a decision, because as I said in the beginning, we have to be very careful when we are talking of involving men, that their role remains supportive, and it should not at the cost of taking away women empowerment for taking the right decision. We cannot just put it under the shambles of it's a patriarchal society, or they are the decision makers. We have to continuously strive to make sure that women are the one who are taking decision. And it's a very, so sorry for pushing you on this, but I really want to learn that as well. And I'm sure the others who are listening as well. Over to you, Dr. Shabir.
Thank you, Dr. Ghazi, and thank you all the panelists for their highly valuable talk. I think the question about that, how did we actually plan or realize that this is an important, this could be an important intervention that could contribute to the supporting the women for post-abortion family planning uptake. So, Dr. Yasmin, if you see, we always mention that post-abortion family planning is a sort of high missed opportunity. That once there is a missed opportunity when a woman has not used or not correctly used the family planning method, or the couple has not used that the family planning method correctly. And the second is, if that woman has passed through that torture of abortion, and that has been unsafe and she has ended up with a complication. So she must be counseled and provided the method so that to intervene that vicious cycle of unsafe abortion we always talk about. So I think this is a shared responsibility. We consider, we believe that women need really high support from their partners, from their husbands in Pakistan context, because the environment where these women go for post-abortion care, the national study mentioned, most of it is the public sector, that the things are happening in back streets due to the legal misunderstanding or misinterpretation of the legal environment, though there are provisions, as Dr. Nasser well said, about legal provision, but unfortunately there's a lot of awareness issues, and certainly the myths and misconceptions and providers' biases are also very important. That the things are unsafe practices are happening somewhere else, and then the complications are coming to the public sector, and these are mostly rural health center and district headquarter hospitals, which the study says. So accompaniment is, I would say, if we see the 3-day or 4-day model, the timely decision making by that woman, that she has to access to a safe provider now, this is the time, that any delay can complicate further. She could have the sepsis, septicemia, lead to maternal mortality. I think that timely decision at the household level, at the individual level, and certainly supported by the household environment, the men are their husbands, they have high important role. So important thing is that why they should support the decision taken by the woman to approach to a facility where retained provider is, that is one of the important things that they have to support. They need to understand what is why that stage has happened, because the pathway that has been followed is not correct. So it's highly important that they need to understand the pathways, what are the needs, where to go, and why, if it's unwanted pregnancy. Certainly, it comes with the joint decision. We have a very interesting finding from one of our conversation with one of the group in family welfare assistance, these social mobilizers, that they disclose that many of the men in their community are coming to them to check about that where to go for safe abortion care in case of unwanted pregnancy. So it means they are an important source of information to the community men, and the decision is happening at that individual level. It's for the married couple, it's not the individual decision, it is a sort of shared decision and responsibility, and men have to provide the support, and particularly during post-abortion care, that the women are led to, they are taken to that facility where a trained provider is. So this should not be again a second missed opportunity for safe care. And we have attached the family planning or contraception as a 4th delay. So this is another unique thing, that realizing that important role and area of work. And when we say the emergency obstetric care for any emergency or coming of women with the post-abortion care, if family planning counseling is not done or family planning method is not provided, that is the delay which is affecting the quality of care. So we have attached that as a family planning or contraceptive provision as the 4th delay in that popular 3-delay model or 4-delay model of quality of care on emergency obstetric care. Now, coming to the training part, yeah, this is very interesting. I think there have been many phases when we were trying to understand from the CAP survey to the user's perspective and bringing them these male community intermediaries to our sessions, consult with them and to talk with them. So the first thing where we have a big stop, that was abortion, that the word of abortion, that we have to start from the scratch. So first to clarify their values. So that is highly important. So values clarification has been a very helpful from the beginning, even from the user perspective, like we were developing prototypes, we had to conduct several values clarification workshops. with these intermediaries, their mid-level manager, the district population welfare officer, the assistant population welfare officers, and certainly the high ups. So we had those champions at the ministry level, as we had Dr. Nasser, Dr. Talib, and I think that sport has helped us or boosted our working potential to the level that we have been consistent to work with these intermediaries. There was a challenging that when there were discussions, like in the first few sessions, they were quite silent. Hardly any mobilizer or family welfare assistant was participating in the discussion. So we have to generate case studies. We have to generate examples where we showed them something that this is happening. These are the complications. We basically motivated them to speak up. So I think it was some of the people who have then become champions from those family welfare assistants, where they started sharing gradually. But the important is the confidence building and generating confidence among them, that they start sharing, they started talking, and that led to development of our intervention and certainly learning from those challenges. Thank you.
Thank you, Shabir. I think in one of our projects that we funded, and of course Ipas is our partner as well, we also tried to measure the change that happens in those that you are training, because they are also married, they have their own lives. Even if they are not married, they have married women. What changes have happened in their own personal life? Have they started believing, practicing? So I think at some point in time, a qualitative evaluation of their own life cycle. So they're not just talking to the communities, but they're making a change in their behaviors. And we try to evaluate that with the community health workers who have been working, what changes had been occurred to them in their behavior. So this is just for the future reference. Now I would like to bring in Amna. Amna has been patient listening to all of us, the older generation. So Amna, it's your time now. So the question I would like to ask Amna is that you are sitting in a company that is testing and piloting innovation. And I know, since I'm one of the board members of PPIF, I know that Men as Partners is one of the strategic themes that were actually looked at. But my question is about, of course, anything that you want to say in that regard, but your experience of working with young people, especially in the backdrop of what has come up as pre-marriage counseling as CCI recommendation. And are you thinking about anything that can happen, not only just the family planning counseling, but if they need advice on post-abortion care and post-abortion family planning? So Amna, over to you.
Yes, thank you, Dr. Yasmin. Yes, certainly, when this company was set up and we were doing background research in terms of finding out what are the gaps, that this company can fill in terms of the knowledge generation and the program planning, youth came out as one very important area. And you've been part of, and leading the technical consultations that we've been having with all the stakeholders, both public and private. And we know certainly that, it's the young people that we need to work with if we want to make any meaningful, changes in this population landscape and the contraceptive prevalence rate and the unmet need that we're looking at. And there is a youth bulge in the country that we need to, take opportunity of. So while there's a lot of, what we saw was that while there's a lot of mention of young people, newly married couples and out of school youth and in school youth and a lot of strategic documents, they have not really translated into implementation plans and action plans on the field. And so there's a very large gap there. A lot of work has happened in the private sector and in the public sector also that we can benefit from. And, through our consultations in the previous year, we've tried to collect that as well and learn from that so that we can, scale that up and our partners can scale that up as well. So we do see that, there is a life skill based education is certainly one step that we need to take for young people. A lot of work has been done. We found a lot of resources developed by the private sector The public sector has also developed some resources for in-school young people. And we are collecting all of that so that, we can coordinate it and come up with a more comprehensive sort of resource toolkit that can be used both publicly and privately. But it's not happening on a structured, formalized, mass scale way. And young people are certainly, from a behavior change point of view, that's the best time and the right time to give them the information. That's not happening. The study from Pathfinder showed that, a woman on an average after her third child is receiving this information. That's too late in the day. The population statistics show us the same also, that the unmet need is highest in the younger age group, and the contraceptive prevalence rate is lowest over there. So information is one, and not just in the usual way of life skill based education, but also through edutainment. I think mass media needs to be involved. We have seen that it has a lot of scope. The digital mediums need to be used. Young people, whether they're in school or out of school, whether in the rural area or in the urban areas, are using digital mediums, and we need to take opportunity of that. Premarital counseling definitely needs to be formalized. There has been some work done here in Punjab. There is a premarital counseling sort of module that has been developed. It needs to be formalized into the system where it is provided, who's going to provide it, and all that thinking is going on right now over here. And I think that's where we can certainly cover these topics of abortion and post-abortion care as well, because we need, that's the time that people are willing to hear, and if there can be some meaningful, change in the way that they are thinking. Because if you're telling somebody right at the realm of affairs, it's very difficult for them to, respond to what you're offering and to understand, because they just, they're working in an emergency situation at that time for themselves. So I think that's one area. If we gradually start breaking in this reproductive health information at the right time to young people, and not just through these, through in-school and out-of-school curriculums and activities, but through mass media, through digital media, so that it is destigmatized among young married couples. They should be, if we're offering, yes, we have to offer youth-friendly services, we have to offer premarital counseling, we have to offer couple counseling, but these young newly married couples or to be married need to feel comfortable going and receiving these services. That's also one issue, that there are so many myths and misconceptions around these services and this information, that even where they are available, there is a challenge that they're not received very well, and these people are not comfortable receiving them well. So there's where we're looking at, where we have all these resources that we have collected, that where are the gaps even in the information. So it might be called life skill based education, but might not cover everything, might not have all the information that is required at that time. So it can be a couple counseling or a premarital counseling module, but it might not cover all the topics, like you said, or post-abortion care. It's very important, because this does happen. There is going to be unmet need. There's going to be unintended pregnancies, and the couple already needs to know what their options are, where they can go. And, we should be able to address the myths and misconceptions in their mind, because it's too late in the day when they get all this information and we try to change their mindset. Yes, the community stakeholders and all the important, influencers make a lot of difference. So religious scholars need to be also involved so that they can give positive messaging around this issue. It's tricky, I understand, but, we need to somehow, because that's, fortunately or unfortunately has a lot of influence in the communities. So somehow with this, we should try to strike a right balance where we get some positive messaging from them.
So sorry, Amna, I need to interrupt because we are running very short of time. And while I would have liked to go with the second round of questions to all of you, it looks like that we don't have time. Am I correct, the Ipas team? We need to close at 3. So, correct? So if Dr. Yeah, that's true. So yes. If so I have to, as per agenda, Dr. Nasir is going to say the concluding remarks. So I'll go to him, although I would have liked just a minute for Dr. Talib to say very quickly what could be the policy looks like if we bring a policy? If you can just say in 1 minute, and then we'll ask Dr. Nasir to conclude, and maybe he could also reflect on this question. Dr. Talib?
Yeah, thank you, Dr. Yasmin. I think there needs a very comprehensive policy response since there's a lot of evidence now available, and we need to have policies and plans at several stages, like at the early stage of adolescent and at the level of early child. We need to inculcate and streamline LSP, life skill-based education, and early child education, which is very important for cognitive abilities. At the level of newlywed couples and the young couples, marital counseling or premarital counseling, these are very important tools. Now they have proven in different countries. Services related to PAC and PAFP, and I'm glad I couldn't mention due to paucity of the time that Dr. Shabir and Ipas team has been doing wonderful work in Hyderabad and Jamshoro districts of Sindh. So we are going to scale up that through, since now we have the policy on PF. Focusing on young people in the universities, it's very important, and we have been doing that work, and we'll like to further enhance that work. Engaging the human resource, we know that human resource, SMM and WA, they are very non-technical person, but need some more technical know-how and knowledge for them. Laws, we need to enforce laws. We have Reproductive Health Act and Marital Bill, and we need to implement that, and we are going to do that. And comprehensive programming like women empowerment, and we are working through World Bank on a new 1000 days plus program. So I think this kind of response.
Thank you so much. These are so proactive, and congratulations to Sindh for doing all that. Dr. Nasir, over to you for closing, and thanks to all the panelists and APAS for having this wonderful panel. Dr.
Yeah. Thank you very much, Dr. Yasmin, and thank you very much, Ipas and the team, Dr. Lashari. What Dr. Lashari has said, that I would like to add that we at the public sector, we need to expand this post-abortion care services in Pakistan and prepare a team of more service providers to take these services to the community. I congratulate all of the panelists for conducting this very successful and very useful session. I'm thankful to United Nations CSW for providing us this opportunity to, to bring our point of view to the world and the public. I finally thank all the participants. Thank you very much. Stay blessed.